Alright, last anatomy exam. I know I always say this, but if you haven't done the lab stuff yet, I would probably do that stuff first. I think if you know where things are located, then what they do, what they're close to, what they're attached to, and what damage to them will cause becomes a little bit easier to understand. But obviously everyone has free will, so do whatever you want. Okay, shout out P again for the PowerPoint or study guide. It's 57 pages. It's awesome, has everything, I believe. Obviously it never hurts to go through the PowerPoints again, the lecture stuff, but she's been very fair with sticking to study guide for exam questions, so hopefully this should be more than enough. Okay, sternocleidomastoid. It's in the name, but it's connected to the sternum, the clavicle, and the mastoid. So this front part connected to sternum, back part connected to clavicle, and then up here connected to the mastoid. So it has the superior attachment to the mastoid, and then the inferior two attachments, sternum and clavicle, specifically medial third of clavicle. Not middle, but medial. So if this is your clavicle, and the neck is like here. That's an awful face. But this is middle third, which is important for other stuff. This is closer to the neck, so medial third. And then this would obviously be lateral third. So each sternocleidomastoid by itself, so the unilateral action, so this is just for the right one or the left one, will tilt the head to the same side, but rotate the chin to the opposite side. So if you have something called torticollis, which is later in the study guide, it's a muscle spasm. So if you have an SCM spasm, let's say a right SCM spasm, so your right sternocleidomastoid is contracting like crazy, so now your head is going to tilt right heavily, but your chin is going to the opposite side. So chin would face or turn left, and we'll see that later on. Now, when your two SCMs work together, so when left and right are working together they will flex your neck, so they'll bring your chin to your sternum. Superficially to the sternocleidomastoid, you have this vein called an external jugular vein. We'll see more about that literally right now, but this will drain, so external jugular vein drains into your subclavian vein. And it's called external jugular, so if this is the body, it's going to be more outside than your internal jugular, which is more inside. So external jugular would be more like this. So internal jugular would be more like here. So external, outside. Internal is going to be more inside or medial. And then the other important thing about sternocleidomastoid is at the midpoint of the posterior border. So this is the front or anterior. So this is anterior border. This back part is the posterior border. So at the middle of the posterior border, you will find something called a nerve point. So that's important, the location of it and the name of it, the nerve point, because you'll have a bunch of cutaneous nerves or branches of something called the cervical plexus, which we will also see in a little. So if you numb that area, if you anesthetize that area, you can get a bunch of nerves all together at once. So external jugular vein, superficial vessel, drains blood from the more external stuff, so like scalp, face, and neck. And then we said superficially to the sternocleidomastoid. Now, your hyoid bone is like your free floating bone. It's below the jaw, but above the laryngeal prominence, which is your Adam's apple, which is part of your thyroid cartilage. Oh my god, awful handwriting. Okay. So small U-shaped bone, front of the neck, below the jaw, above the Adam's apple, whatever. Only floating bone, so that's an important thing. It's also not a sesamoid bone. Sesamoid bone just means that like it doesn't like form within a tendon, or it's not like a pulley for a muscle. Sometimes you'll have like bellies or something of a muscle that will either pull in, contract, or expand depending on the muscle movement or whatever. So it doesn't do that. It's literally just like a free floating bone. Does not directly connect to any other bone, like we said, but rather connects to muscles and ligaments, and then it's suspended by a muscle attaching to it superiorly, inferiorly. You have ligaments, you have thyroid cartilage, which would be below it, because we said this is above the laryngeal prominence or Adam's apple, which is part of your thyroid cartilage. And then this is what separates suprahyoid and infrahyoid muscles, which makes sense. If they're above the hyoid, they are suprahyoid. If they're infrahyoid, they are below the hyoid. And then the infra ones are called strap muscles as well. So, suprahyoid muscles. You have... So for the muscles with two bellies, we have the digastric, and then we have the omohyoid. Digastric is a suprahyoid muscle. Omohyoid is infrahyoid. The way to kind of remember this, and this is kind of more like lab stuff, but I remember D, H, O. So in alphabetical order, D comes before O, and H is like in the middle because that's your hyoid bone. So the digastric is the muscle that's above the hyoid or suprahyoid, and the omohyoid is the muscle below the hyoid. Digastric has anterior and posterior bellies, and then omohyoid has superior and inferior bellies. Now, the name of the muscles correlate with what they're attached to. So stylohyoid should be T. So stylohyoid would connect from the stylus or from the stylus process in the skull to your hyoid bone. Mylohyoid will go, there's a part of the mandible called the mylohyoid line, so it connects it from there to the hyoid. So the names, if you understand the names, you'll understand the connections. Let me go back up here. So, erase all this. This is the hyoid. So, for suprahyoid, you have this stylohyoid right here. This muscle right here. It's going from the stylus, which you can't see, the stylus process behind, to the hyoid. There's a key relationship between the stylohyoid and the posterior belly of the digastric. And this is more like a lab thing, but the posterior belly connects to the mastoid process, obviously behind this because we can't see what's behind this. The stylohyoid connects to the stylus process. The stylus process is more, or styloid, I keep saying stylus, styloid process is more anterior than the mastoid process in the skull. So the stylohyoid, you see how it's anterior to this posterior belly. So in lab, if they pin one of these two muscles, if they pin the back one and you see another muscle in front of it, then that means the one in the back is the posterior belly of the digastric. If they pin the anterior one, it's the stylohyoid. Mylohyoid, you can see up here. And then digastric, this is anterior belly, all the way to posterior belly. So this is anterior, this is posterior. And then you can't see geniohyoid in here, but it would be like higher up than the mylohyoid. So it's like more deep. So those are your suprahyoid muscles. So you have stylohyoid, mylohyoid, geniohyoid, and then the two bellies of the digastric. Now for infrahyoid, so this is below the hyoid. These are nice because their names give you the connection from bottom to top. So you have, this should be sternothyroid. So sternum to thyroid is sternothyroid. So this is our sternum, this is our thyroid, and this is our hyoid. Sternum to thyroid is sternothyroid. Thyroid to hyoid is thyrohyoid. Now, superficially or more anterior to both of these, you have sternohyoid, which goes all the way from here to here. So this whole thing, a muscle going all the way would be sternohyoid. And then the omohyoid is the one that we said has two bellies. So if we go back up here, this is the hyoid. Now we're below because these are infrahyoid. So we said most superficially you can see sternohyoid. If you removed this behind it, you could see the thyrohyoid and sternothyroid, which you can actually see thyrohyoid here. Sternothyroid would be lower behind this. But the key thing here is your omohyoid muscle. So superior belly, inferior belly. So it goes like this. And what you start to notice with these is you can kind of form a bunch of triangles with this stuff. So you can see a triangle if you use this anterior belly with a posterior belly, and then if this person was looking up, the mandible would be straighter. That's a triangle. You can see the big triangle, which is anterior to the sternocleidomastoid. If you use like the midline of the neck is like an imaginary line, so you can make two triangles. And then the mandible would be a line here, or a triangle. For a posterior triangle, you have back of the SCM, you have your clavicle, and then you have the front of the traps. So this is a triangle as well. And then you can start splitting these triangles. So for the posterior, if you use this inferior omohyoid belly, now we have a lower triangle, which is going to be called subclavian. And I'll redraw all of this stuff. Also, let me use a smaller. And then this is going to be your occipital triangle. So these are just examples of like how we use these muscles to make all these triangles, but obviously we'll draw all of this stuff out so we can see it clearly. Okay, and then the hyoid supports the tongue, larynx and throat, speech, breathing, swallowing, everything in like that neck area. It's situated at the level of C3, so she could ask that. That's important. And then we already said it's attached by muscles and ligaments, and it's not a sesamoid bone. Now, thyroid cartilage is this entire thing here. Within the thyroid cartilage, you have this thing popping up right here, and that's your laryngeal prominence, or Adam's apple. So that's the part of your neck that you can feel clearly. It's more prominent in males, not to like brag or anything, but it's like that's just a factual thing. It's U-shaped. You can kind of see how it's like U-shaped, whatever. Protects the larynx, located in the neck. We know it's below the hyoid because we already said the hyoid is above this. Then the Adam's apple or laryngeal prominence is the specific V-shaped thing where two plates of the thyroid cartilage meet in the front. So this and this are going to meet here in the middle. So the whole overall structure of the thyroid cartilage, the laryngeal prominence is just a part of it, or it's the specific, visible, palpable part. So it's a feature of the thyroid cartilage. Cricoid is right below it, right here. This is important because if you've ever seen, like in TV shows, how if someone can't breathe, they'll do a cric or like a cricothyrotomy. They'll actually use the Adam's apple as like a mark of like where they need to like stab through to open up and create an airway so the person doesn't like die. It's the only complete ring of the hyaline cartilage, surrounds the trachea. It's at the inferior border of the larynx at the C6 level. So she could definitely ask about these levels. We said hyoid was C3, cricoid cartilage is around C6. And then we said it's a complete ring, and then it's a singlet ring, anchors the larynx, the trachea, provides critical structural support. Okay. Now, the triangles of the neck and their boundaries, borders, contents, everything. So let's go back, or here, let's draw this stuff out over here. Let me use this tiny thing. So we said, let's start with posterior triangles. So for posterior triangles, we have, if we use the back of the SCM, so the posterior border of SCM or sternocleidomastoid, if we use the anterior border of the traps, you really just need to remember like SCM and traps, but I'll explain why it's like posterior border, anterior border. And then if you use the clavicle, so inferiorly, you have the clavicle. This is like anterior is the posterior border SCM, posterior is the anterior border of traps, and the inferior is the clavicle. So this is your, here, let me go back to this picture. So the front of this triangle is the back of the SCM. That's why I'm saying the anterior part of the triangle is the posterior part of the SCM, if that makes sense. So technically for the other triangle, the posterior part of this triangle would be the anterior part of the SCM. So I hope that makes sense. And back here. So we have SCM, clavicle, and then in the back we have our traps. So the front of our traps is the back or most posterior part of this triangle. Now, that's the big posterior triangle, but this can be split into two triangles by this inferior belly of the omohyoid. So actually, let me use a different color here. So this is inferior omohyoid. So now you have this triangle here, and you have this triangle here. So this orange one is your occipital triangle. The green one would be your subclavian triangle. So now let's look at the borders of the subclavian. You have this part, which is your clavicle. Specifically like the middle, not medial, but middle third. And this is an important relationship. So start this. Because if you have damage to the middle part of your clavicle, you can damage your subclavian vessels, which we will talk about. And then this border would be the SCM. So you have the clavicle as a border, SCM as a border, but now your traps are in a border. Your inferior omohyoid now is your third border. So inferior omohyoid. For the big triangle, like the entire triangle, your traps were a border, but now we split it into two. Now this occipital should be similar. So now the bottom part of this occipital is the inferior omohyoid. Inferior omo. The front part, still your subclavian, not subclavian, sternocleidomastoid. And then the back part are your traps. So hopefully this makes sense of why these are the borders for each of these triangles. So big triangle, big posterior triangle, those are your borders. For occipital, these are your borders. Subclavian, these are your borders. And then we'll talk about the actual contents of them after this. But I want to make sure the borders are good. Now, for the anterior triangles, let's start with black. So right on your chin, remember we said you have anterior belly of digastric, posterior belly of digastric. And then anterior to this posterior belly, you have something called a stylohyoid that runs like anterior to this. So these digastric bellies are going to be very important for the anterior triangles. So the big anterior triangle, though, so let's go all the way back up to page 1. The big anterior triangle is going to have 3 borders. So now we're going to be anterior of the SCM. We're going to use the mandible now. If this person was looking up, like this would be moved up. And then we're going to use an imaginary midline, or what we call like a mid-sagittal line. Sagittal is just like vertical coming down. That's why, like, when we talk about sagittal sinuses, you have one superior sagittal sinus, one inferior sagittal, like straight across, cutting down the middle. So, for anterior triangles, sorry if this is annoying, moving back and forth. I'm just trying to, like, make sure that this makes sense. So, anterior triangles, the main triangle's borders, main big one, so we haven't split it up yet, are going to be the anterior SCM, the imaginary midline that we made, and then the mandible, technically the bottom part, inferior of mandible. So, SCM, imaginary midline, and then mandible. First triangle we have, this one is unique because it actually is just one triangle. So it doesn't, you don't have 2 of this triangle. It's just one big triangle, and it actually goes through the midline. So imagine this part of the midline wasn't here. Oh my God, why am I shaking? So you have an anterior belly of digastric, so I'm going to say AD. And then you have another anterior belly on the other side. So imagine this is like your chin right here. So we're talking about right below. So this is the left side of your body. This is the right side of your body. This triangle would obviously also be on this side. So whatever you do to one side, you mirror to the other side. But you have one triangle here using both anterior digastric bellies. And then you use this part right here, which hopefully by now we know this is the hyoid bone. So this triangle, let's do blue, is your submental triangle, which is going to have your submental lymph nodes. And we'll go over those contents. So the borders of your submental, you have both anterior bellies, so right and left, of digastric muscle. And then the other border, or the bottom part, is your hyoid bone. So that's your submental triangle. Now, if we continue this digastric, so that's the anterior belly, now we're going to give it a posterior belly. So posterior digastric, and we know this top part is the mandible, so we have another triangle. So this green triangle is your submandibular triangle. So this one the borders of this are anterior belly digastric, posterior belly of digastric, and mandible. So hopefully these make more sense now. So anterior digastric, digastric, posterior belly digastric, and mandible. And then remember, we said only the submental had only one. All of the others, you have a right and a left. So we can make the same triangle here on the left side. So right submandibular triangle, left submandibular triangle. The other two will have the same thing too. Now, if we use this posterior digastric, and then we use the sternocleidomastoid, and the superior omohyoid. So we're going to have a muscle. Let me go back to the first page. The superior omohyoid, which starts at the hyoid, comes down, and then later on gives an inferior. So if we use the superior omohyoid with the SCM and the posterior digastric, now we have a triangle in here. So superior omohyoid, starting at the hyoid, we're going to bring this down. So this is superior omo. So for this red triangle, this is our carotid triangle. So for carotid triangle, oh my lord, we have posterior digastric or posterior belly of digastric. We have the sternocleidomastoid, and then we have our superior omohyoid belly. And then finally, and then obviously we would have this on the other side too. So it would be like this. That's your triangle there. So this triangle is the same as this triangle, because we have right and a left. And then finally, we have our muscular triangle. So for this one, let's do orange. We're going to use this mid-sagittal line. And then you can kind of already see how the other parts of this are going to form. So you would have the sternocleidomastoid. And then, let me fix the superior omohyoid, because it's coming from the hyoid, so it technically, oh my lord, it should be more like this. Okay, so sternocleidomastoid, superior omohyoid, and then the mid-sagittal line. So then this is your muscular triangle. And then we're going to have two of that, so one on the right, one on the left. So your muscular triangle, you can probably guess it, has most of these muscles that are infrahyoid. So the border lines or borders of this are your midline or mid-sagittal line, your sternocleidomastoid, and then your superior omohyoid. So superior omohyoid separates your muscular and carotid triangles. Inferior belly of omohyoid is what separates your occipital and your subclavian, because it makes sense. The inferior part's in the posterior, superior part is in the anterior. So hopefully this at least made sense with the drawings. If not, I'm sorry. But that'll make like the next few pages sort of fly by. So triangles of the neck, its borders and contents. You can split the neck into smaller areas, triangles. Each cylinder, or each is cylindrical. Mid-sagittal line, the thing we said, we'll split into two triangles. So for the right side and the left side, and then you can use the SCM. So that's what separates anterior and posterior triangles. Anterior stuff will ascend, AA. Posterior stuff will be coming down. And then, I mean, these are all the borders we talked about. How you can further divide the posterior using the inferior belly. And then they're called occipital and subclavian, the posterior. You have four muscles in the posterior. You have your splenius capitis, which is all the way back of the neck. Levator scapula, literally elevates scapula. And then you have your scalenes. You have posterior and middle. Sometimes anterior scalene also will play a role in the floor of this. But usually it's covered by the SCM, so you don't see it much. A key thing between the middle and anterior scalenes is between middle and anterior scalenes, your brachial plexus runs. So brachial plexus between anterior and middle scalenes. So you can assume it's behind the anterior and in front of the medial. The anterior scalene is also another reference for the phrenic nerve. Phrenic nerve is anterior to anterior scalene muscle. But that we'll see that later. Oh, actually I lied. Brachial plexus right here. So between middle and anterior scalenes. Spinal accessory nerve, which is cranial nerve 11, which innervates your SCM and traps, or trapezius muscles, which says that right here. This runs superficial to your levator scapula. It's specifically within the occipital triangle, because this is the back triangle. It's the back or posterior bigger triangle that we talked about. So it's specifically within that. And then anterior triangles, the big triangle, you have your SCM, your midline, inferior border. Then you can make it into 4 smaller triangles, and this kind of shows the stuff. For submental, it runs across. So that whole thing is submental. And then you have submandibular, carotid, muscular. So you have 4 triangles. And then you'd have the same thing on the other side. But submental is just 1. So here it says spans the midline, so it goes through the midline. That's why you only have 1 triangle. So no right and left. You use both digastrics and the hyoid bone. So we talked about the borders. Okay, these are some of the contents. So this is probably some of the important stuff. So for submental triangle, you get submental lymph nodes. It also has an anterior jugular vein, which I guess is whatever. For muscular triangle, we talked about the borders, midline, superior hyoid, SCM. But now these are your strap muscles, which we said are your infrahyoid muscles. And then the stuff lower. So you have thyroid, parathyroid, and then some vasculature and nerves. But the key thing here, it's muscular triangle, your strap muscles are there. Now for occipital triangle, this is the posterior triangle, the bigger one, the larger one, has the occipital artery. Makes sense. We already said the spinal accessory nerve goes through, which is cranial nerve 11, which hits your SCM and traps. You have trunks of the brachial plexus and branches of the cervical plexus that run there. And we know this because remember we said posterior border of SCM around the middle is where you have that nerve point, which has to do with your cervical plexus, which we'll also see. Cervical lymph nodes, and then we know the boundaries. So SCM, traps, inferior belly hyoid. Subclavian triangle, we know the boundaries as well. It's subclavian, so you would assume that it has the subclavian stuff in it. So subclavian artery and vein. And then if the external jugular vein drains into the subclavian vein, it makes sense that the bottom part of it, so where it's draining, would also be here because the subclavian vein is also here. And then this triangle is above the clavicle, so it makes sense that you have your supraclavicular lymph nodes. Sometimes it has the suprascapular artery, whatever, and then we saw the boundaries already. This. Submandibular, we saw the boundaries, mandible, posterior and anterior digastric. Key thing here is submandibular gland, but you also have your 12th cranial nerve, the hypoglossal nerve in there. So we said cranial nerve 11 goes into the occipital triangle, but 12 is in the submandibular triangle. So she could definitely ask those stuff. And then lymph nodes as well. And then lastly, carotid triangle. We talked about the borders. And then if it's a carotid triangle, you can have your common carotid artery. Now, where your common carotid artery runs is within a sheath called a carotid sheath. Your common carotid artery runs right next to your internal jugular vein, and right in between them you have a tiny nerve called the vagus nerve. Well, not tiny, it's a long nerve, but nerves are obviously smaller or thinner than veins and arteries. So you're also going to have so if you have common carotid, this splits into internal carotid and external carotid artery. You'll know the difference, especially in lab, because the external carotid artery branches, but the internal carotid doesn't branch until all the way it gets to the top in the brain. Later, it'll become the MCA and ACA. Middle cerebral artery and anterior cerebral artery. Not cerebellar, cerebral. But the external carotid you can tell is because it branches, and we'll go over the branches as well. So, like we said, you have an internal jugular vein, your vagus, external carotid, internal carotid. The branches of the external. You notice how it didn't say branches of internal, because internal doesn't branch. It just goes straight all the way up into the brain. And then there later, it becomes MCA and ACA. Okay, so the carotid sheath, we already talked about it. It has your carotid arteries. So the common carotid artery, which later will split into internal and external, internal jugular vein, and vagus. Then you can see the ansa cervicalis, which we will also see, superficial to the carotid sheath. It runs superficial to it. And then this is your carotid sheath. So blue is going to be your vein, so internal jugular vein, vagus nerve in between, and then common carotid artery. Later, you'll have external carotid and internal carotid. This picture isn't very representative of how external runs. Obviously, they want to show that external eventually will go to the outside or more superficial stuff, lateral. But the way it runs, and I think there's another good picture, is first, so this is your common carotid artery. First, when it breaks up, external kind of goes this way, medial, and then it goes that way. Whereas internal goes a little bit medially. Sorry. External will run medial. So let's say this is the medial side and this is the lateral side. External will run a little bit medially first, and then it'll go laterally. Whereas internal will start a little bit laterally, then it goes straight up into the brain. So this is like the medial part, the middle of your body. So, phrenic nerve and brachial plexus. So this has to do with your scalenes. So we said that brachial plexus between your anterior and middle scalene. Technically, it's called like a scalene triangle, which has your brachial plexus, and will have your subclavian artery as well. For brachial plexus, remember it's Randy, Travis, drinks, cold beer. So you'll start with roots, then trunks, then divisions, and then chords. Does chords have an H or no? I think it does. And then branches. So the roots, which are like the first things, these are your C5, C6, C7, C8, and T1. And then trunks are when they start combining. So C5, C6, C7, C8, T1. 5 and 6 will combine, make your superior trunk. 7 becomes your middle trunk. 8 and T1 becomes your inferior trunk. And then you start getting all the crossing for divisions, chords, whatever, branches. But yeah, so the trunks will be deep in the posterior triangle. And then later on, you'll get your divisions, chords, and branches. And we saw the subclavian artery passes near them, superior to the first rib. Your subclavian artery actually has 3 parts to it, which we'll see. It gets separated by parts by the anterior scalene muscle. So anterior scalene will separate into 3 parts. And then after those 3 parts are done, later it just becomes the axillary artery. And then we talked about the divisions of the brachial plexus. And then we already said this, but phrenic nerve goes anterior to anterior scalene. This is your C3, C4, C5. Keeps the diaphragm alive. Okay, now cervical plexus. So this is the stuff when we were talking about when we said the posterior border of the SCM, around the midpoint, you have the cervical plexus. The specific spot, middle of SCM posterior, is your nerve point, where all of these are located. Exiting location for these branches of the cervical plexus. So it's the main point for anesthesia, because if you want to block something, you want to find a point that you can block everything at once. So based on the names, you can kind of tell which one's higher and which one's lower. So lesser occipital is going to be like back of the head area. So this is going to be the highest one, C2. When we say auricular, this has to do with like ear. So your ear is a little lower. Transverse cervical, so the cervical part of your neck, also a little bit lower, because now we're in the actual like ear to like upper neck range. So these are going to be C2, C3. And then supraclavicular, now we're higher up. This is going to be C3, C4. There's a good picture all the way here that shows these. So lesser occipital is here and here. Shows you it's like back of the head. The auricular one's going to be around the ear down here, so that you can see that transverse cervical and greater auricular both start here, so they get C2, C3. The lesser occipital just gets C2, and then transverse cervical gets like 3, 4, and then it will go down to do like the supraclavicular stuff. And then this picture shows all of these as well, and where these supply. So lesser occipital is going to supply neck, posterior scalp, higher, so superiorly to the auricle. And now we go a little lower because now we're at the auricle, and then you'll do like the inferior aspect of the auricle, and then you get like the angle of the mandible, and then the mastoid process, which we talked about, is a attachment to the SCM and a few other muscles. Transverse cervical is going to do anterior cervical regions, and the supraclavicular is going to be the skin over the shoulder and clavicle. Now, she loves exceptions, so if she says which of these is not a branch of the cervical plexus, and she gives you any one of this, she gives you 3 of these, and then she throws in greater occipital or third occipital, then these are not branches of the brachial plexus. But they do stem off the posterior rami of the cervical nerves. So that could definitely be like an exceptions question. So what the cervical plexus does, it's cutaneous somatic innervation of the neck. From C1 to C4, you can separate them into cutaneous and muscular branches. And then the muscular branches, so think about the muscles we've seen in the neck, are going to do the suprahyoid and infrahyoid muscles. So the C1 branch will hitch a ride with the hypoglossal nerve, which is cranial nerve 12. And you can see that over here. This is C1. Hypoglossal will hitch a ride right there. So in lab, when we see the hypoglossal nerve, now because they're not dissected well, or they always cut the ansa cervicalis when they dissect it, we should be able to see this going down and how this comes like this and it combines, and then this does a bunch of your muscles like omohyoid, sternothyroid, sternohyoid, inferior belly of omohyoid, but it's never that perfect. Just like life. Sorry, that was deep. So, yeah, so hypoglossal runs with C1, and it separates into 3. So then you'll get this stuff. These are not part of ansa cervicalis. Ansa cervicalis is this superior root and then this inferior root. So technically ansa cervicalis is C1, C2, and C3, but these 3 on the side are not ansa cervicalis. So when we talk about muscles innervated by ansa cervicalis, this is another exception thing. Thyrohyoid is not innervated by ansa cervicalis, but sternothyroid is and sternohyoid is. So that's a key note. So thyrohyoid not innervated by ansa cervicalis. But if you follow it up, it's just C1. Only C1. So for ansa cervicalis, it's omohyoid, sternothyroid, and sternohyoid, which we said. This is just inferior and superior belly of omo. Then you have sternohyoid and sternothyroid. And it's superficial to the carotid sheath. We saw this already. So here you can see how C2 and C3 will fuse, and then they'll give you the inferior root. And then, well, you know this, C3, C4, C5, keep the diaphragm alive, phrenic, PHR for phrenic, PHR for diaphragm. And then phrenic, we already said, is superficial to anterior scalene. So the nice thing is, like, all this stuff kind of overlap, and they keep repeating similar points over and over again. So for this stuff, she said she'll definitely ask a question on this. So she could say, like, what does it supply? Or she could specify, like, a region. Like, put the back of the scalp. You should know it's greater occipital. Or, like, right around the ear, greater auricular, anterior cervical, so transverse cervical. Or, like, above the clavicle and all this area here, and supraclavicular. This stuff, again, we've seen already. Infrahyoid muscles, so below the hyoid. These are the ones that have the names going from bottom to top. So sternocleidomastoid, sternocleidomastoid, sternothyroid, thyrohyoid, omohyoid. The key difference is these are all antecervicalis. And just like we said, this is not. It's just C1. So muscles below the hyoid or infrahyoid, we also have called them strap muscles. If they're lower than the hyoid, they're going to depress or bring down the hyoid. So the suprahyoid ones would elevate the hyoid. Infrahyoid muscles are primarily innervated by antecervicalis, with the exception is the thyrohyoid. Like, know this, like, super important. And then we already saw this. Now, for right heart catheterization, what do? Think about, I know the heart stuff was like last exam, but think about the location of the main vein in the heart. So, if this is our heart, veins will bring blood to the heart, arteries will bring blood away from the heart, or take blood away from the heart. The main vein is your superior vena cava, which is located on the right side of the heart. So, if you want to do a catheterization, what is the best landmark? And the best landmark is the right internal jugular vein. Because remember, your right internal jugular vein, so if this is the neck, you have a right internal jugular vein coming down. So right IJV. This is your right subclavian. When they combine, this right here is your right brachiocephalic vein. Brachio means arm, cephalic means like neck, head. So arm, head, subclavian, intrajugular vein. And then that goes into your superior vena cava. So if you want a direct catheterization, you'd go right internal jugular vein for a straight shot into the superior vena cava. So straighter pathway makes it safer access into superior vena cava. And then where you would do this is between the two heads of the sternocleidomastoid. So remember, we said sternocleidomastoid. So it has a sternal head, a clavicular head, then a mastoid head all the way up there. So you go between the two heads of the sternocleidomastoid. And then straight shot down in the right internal jugular vein. So between two heads of the SCM, that's how you get into the internal jugular vein. And then obviously the two heads are the sternal head and the clavicular head. Mastoid head is all the way up here, which we don't want that one. All right, carotid body and carotid sinus innervation. So we have a common carotid artery, which will split into an external carotid artery and internal carotid artery. And this split happens at the level of C3, C4. She loves numbers, so she could possibly include this. This is back. And obviously, arteries are coming away from the heart, so this is splitting as you go up. So this is... No, please don't die right now. Give me a second. Okay, so common carotid artery, it's 93. Common carotid artery, then you're going to have external and internal. And remember how we said it's they have like a weird thing where like it starts medial then goes lateral, or starts lateral then goes medial, depending on the artery. Now, the internal carotid artery has a small swelling, S for swelling, S for sinus, near the bifurcation. And then remember we said internal carotid, it's not going to branch off, it's just going to go all the way up and go through the skull, through something called the carotid canal, which we'll see when we're doing the cranial nerve stuff. And then later, eventually becomes the MCA and ACA. Now, at the bifurcation, you also have something called a carotid body. So, the sinus, which is the swelling on the internal carotid artery, is a baroreceptor. So it reacts to changes in arterial or blood pressure. The body is a chemoreceptor, which reacts to changes in oxygen levels in the blood. So both of these are innervated by cranial nerve 9 and 10. So a way to remember this is, if you're walking in the street or whatever, you're walking with someone, and you see a cute girl, you go like, hey yo, she's definitely like a 9 or a 10. So A, arterial pressure differences, or O, oxygen levels. To remember which cranial nerve innervates them, it's the 9 and 10. So glossopharyngeal and vagus. And then remember the swelling, S for swelling on the ICA, is your sinus. And then at the bifurcation, so it's not specifically for internal, external, but at the bifurcation, you have the body, B, B, S, S. So here, oh, this does a really good job of showing what I've been trying to explain. So this is your common carotid artery. This is your external. And the reason we know it's external is because we see branches. So in lab, if they pin right here, you say common carotid artery because it hasn't split yet. If they pin this artery, you see branches, immediately external carotid. But you can see how the external carotid goes medially first and then goes laterally to do like the superficial or lateral or external part of the face, scalp, neck, whatever, all this stuff. Internal will do the opposite. Goes a little bit laterally first, then it'll go medially straight into the brain. Doesn't branch, but later becomes MCA and ACA, which we'll also see. So this is what I was talking about, where it starts medially, then goes laterally, or starts laterally, then goes medially. Just know the names are like where they eventually end up. So external is going to end up outside, or external, or more lateral. So the sinus, S swelling, S sinus, is on the internal carotid artery. But the body is at the bifurcation, B for body. So it's not for either one of them, but it's where it splits. So hopefully this makes sense. And then chemo, chemical, oxygen, baroreceptor. You can remember like blood changes, so arterial pressure, like blood pressure stuff. Okay, hopefully that helped. So AO, that girl is a 9 or that girl's a 10, whatever. So now, external carotid artery and the branches. So for lab, I'm going to specify this is for lab. Lab, we only have to know 3 branches. And the location of the branches will make sense, which one's higher, which one's lower. So the 3 branches in lab, so after your common carotid artery, you have external goes like this, but then goes like this. And then internal goes like this, whatever. So external is going to, for lab, the first branch, it's going to go to your thyroid and the top part of your thyroid. So superior thyroid artery. That's the first branch. The second branch for lab is going to go to your face and its facial artery. And the last branch is going to go all the way to the side of your head. Because remember, we're doing like superficial, outside the skull. So this is going to be superficial temporal. So these are the 3 branches for lab. Here, obviously, we're going to have to know more branches. But the key thing is superior thyroid artery is your first branch. Again, arteries are going away from the heart. So your first branch, if this artery is going up, is going to be the lowest branch, which is your superior thyroid artery. Okay. Major artery originating from the common carotid artery. We already said that the bifurcation happens around C3, C4, so makes sense. Thyroid cartilage is in that range, around C3, C4. This gives blood to the face, scalp, and neck. Now, the last two branches, or the terminal branches of your external carotid artery, even though these aren't, actually one of them is in lab, are your superficial temporal, which we talked about, and your maxillary. So this last division happens around the parotid gland, which is like the cheek side, like lower cheek side of your face. So now the external carotid artery, superior thyroid artery, first branch. That could be an exam question. What do you think it's going to supply? Thyroid gland, and what's around it is the larynx. These arteries, what they supply is in the name. So lingual, tongue. Posterior auricular, remember we said auricular, ear. Facial, face. Occipital, back of head. Because remember when we talk about the occipital, the greater occipital nerve, which is part of the cervical plexus, we said is like back, lower part of your head. You have your occipital lobe there. Anything occipital is going to be in that range. Ascending pharyngeal, pharynx. Maxillary is going to be, so we're talking about like cheek side, a little bit higher up, so it's going to be the deep structures of the face, including the teeth, more like upper teeth, and then mastication, muscles of mastication, which is like your chewing muscle and meninges, and then superficial temporal, also another terminal branch. So these are both terminal branches. This will do side of the head and the scalp. And you can see that all the way here. So superior thyroid, first branch, and then we'll get the pharynx one, then the tongue one, then the face, then the back of the head, the ear, maxillary, and superficial temporal. Okay, subclavian artery. So we mentioned this before, but where is it? I think I'm blind. Okay, whatever. It might be a little bit after. Oh yeah, there it is. So what separates the subclavian artery into three parts is your anterior scalene muscle. So if you look at this picture, this imaginary red thing, all the way here is your anterior scalene. So posterior to it is going to be your costocervical trunk. Medial to it are these three branches, and that's your first part. And then lateral to it is going to be your dorsal scapular artery. This is technically your common your brachiocephalic trunk, which is only on the right side, because your left side, the common carotid and subclavian just comes straight off the aortic arch. And then this is technically like your common carotid artery. And then now this whole thing, awful choice of color. This whole thing is technically your subclavian. So you'll have this first part, second part, and then third part. And these are in relation to the scalene, specifically anterior scalene muscle. So subclavian artery, main arteries in the neck are your common carotid, subclavian, whatever. Subclavian artery gives rise to the vertebral artery, which we can see right here. Remember, this is the artery that goes through the transverse foramina of C6 and up. This was like first exam stuff. Goes through transverse foramina of C6 and up. And then this was also like in lab stuff, because the main arteries in the lab stuff are vertebral, basilar, and internal carotid, all the way up in the brain. Give rise to vertebral artery before continuing on, providing muscles or blood to muscles of the back and upper limb, and that's like later on. Comes off the brachiocephalic trunk on the right, which we just said, but on the left it comes off the aortic arch with the left common carotid artery. Later on, when it's done with the three parts, it becomes the axillary artery. So it becomes the axillary artery, specifically when it crosses superior to the first strip. So that's an important location because they've mentioned that multiple times. And then divided into three parts by the anterior scalene muscle. Super important. So first part, medial, you're going to get vertebral, internal thoracic, thyrocervical trunk. The names, again, are nice because internal thoracic is going to do anterior chest wall. Remember when they pulled out the rib cage in lab and they were like, what is this? And it was the internal thoracic artery, or the nerve also runs there as well. vertebral artery. This is what we said. Goes through transverse foramen to C6 and goes up all the way through the foramen magnum, and it's going to go supply the brain. Specifically, it's going to have a branch called pica, posterior, inferior. This is cerebellar, not cerebral, artery. Also, lab stuff. So it sends to supply the brain. Thyrocervical trunk, thyrocervical, so it's going to do inferior thyroid artery. This is important. Inferior thyroid artery comes off of thyrocervical trunk. Where do you think superior thyroid artery comes off of? We've seen this already. It's from the external carotid artery. Remember, it was the first branch of external carotid. And if you don't remember, there you go. Okay. All right, sometimes can give rise, whatever, suprascapular, transverse cervical. Okay. Also, now the second part, remember, that's where the anterior scalene is, so this will be posterior to it, and it's the costocervical trunk. When you have costo, it's like rib stuff, so the artery there is going to be between the ribs, or intercostal. And then later you have the dorsal scapular artery, and this is like back scapula, so this is going to supply things like your rhomboids, like your levator scapula, and what else is there? Your traps. Okay. So, again, separated by anterior scalene muscle. The muscle passes in front of the artery, which we know because we said the artery is posterior to it. Separating it into the first, which is medial, second posterior, third lateral, before later on becoming the axillary artery. All right, we said this already. And this shows you a picture of the three parts to it. And then later on, after the first rib, now it's called axillary artery. Okay, so remember when we said your subclavian triangle, so trying to relate this back to the other stuff. Remember when we said your subclavian triangle, the lower border of it, so remember subclavian triangle had inferior belly of omohyoid, and then if you remember the posterior part, it was the clavicle, specifically the middle third of the clavicle. So remember we had inferior omohyoid, we had the SCM coming this way, and then we had your, okay, this is an awful triangle, but it was like this. So you had your middle clavicle, you had your SCM, because this goes all the way up, and then inferior belly of omohyoid. That's your subclavian triangle. So within there are your subclavian vessels. So if this inferior border is specifically the middle, not medial, middle third of clavicle. So if this whole thing is our clavicle, this is the middle third. We split it into three, this is the middle one. That is where it's at risk of fracture because it's the thinnest portion of the clavicle. You have your subclavian veins and arteries there. The vein is the one that's more likely to be damaged because the artery is posterior to the vein. But they're most likely both going to be damaged. So if she'll ask a question, she'll be like subclavian vessels, which is both vein and artery. But the vein is more susceptible or more at risk because it's more anterior. And then torticollis, we talked about this. This is when your SCM spasms. So in this case, it's this SCM that spasmed. So neck bends this way, chin goes opposite way. Okay, pharynx. So you have pharynx and larynx. This is probably some of like the newest or newer stuff. This is a tube bounded by muscles. You have your Okay, sorry, I was just reading text. It's a long muscular tube behind the mouth and nasal cavity, shared pathway. You have air that goes, food that goes, and liquid that goes. So you're breathing and you're eating from similar areas. So there has to be something that protects us from combining these different things. It's crucial for both, like we said, respiratory and digestive systems. Make sure air moves to the larynx. Don't want food in there. And food goes to the esophagus. Don't want air there. So we have nasopharynx, oropharynx, and laryngopharynx. This stuff, if you know the lab stuff, will make a little bit more sense. So it's behind the nasal cavity, superior to the soft palate. This is our mouth. This is the tongue. This entire top part is the palate, or the top of your mouth. If you feel the top front 2/3, it's a hard palate. All the way in the back is a soft palate. So nasopharynx is this entire area right here. From the back of the soft palate up. And there's a couple important things in here. At the top, you get this thing called the pharyngeal tonsil. And then there's a tiny opening in here called an opening of the auditory or eustachian tube. So that's nasopharynx up here. Down here is going to be oropharynx. Lower, you're going to get laryngopharynx. So I hope that we know that from our nose. So it's called nasopharynx because if you kind of just like follow it forward or anteriorly, just your nose. Oral region, oral cavity is your mouth, and then laryngeal, because in front of it is your larynx. So I hope that from our nose we're only breathing. No food should be going there. And then key features: pharyngeal tonsils, aka adenoids, eustachian tube, we said. And then that's important for like middle ear, pressure equalization, blah, 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 whatever. Oropharynx. Here, you'll get part of both digestive and respiratory because you can breathe in from your mouth. And food goes in there as well. Here, you get a palatine tonsil. So, pharyngeal tonsil is in your pharynx. Oh my God, I hate that sound. Okay, so pharyngeal tonsil is going to be at the top of your pharynx. This whole thing is your pharynx. Palatine tonsil is going to be where your palate is. So this is oropharynx because this whole thing is your palate. So it makes sense that this gets palatine tonsil, not pharyngeal tonsil, which would be nasopharynx. And then it goes from the soft palate all the way to the epiglottis, like we said. So from back, soft palate, all the way to epiglottis. And then this epiglottis, that's the thing that like bends, depending on if you're breathing in or if you're eating, to make sure that stuff doesn't go in the other or opposite thing. The laryngopharynx is going to be after the epiglottis, all the way to the cricoid cartilage, level of C6, which we already saw earlier. And then later on, it's the esophagus. Also, food and air will be going through here because of the lower part. Behind the larynx, it's a junction where food goes to the esophagus, separating it from the laryngeal inlet. So now, muscles of the pharynx. We have constrictors. You have a superior pharyngeal constrictor, a middle pharyngeal constrictor, and an inferior pharyngeal constrictor. All are innervated by the vagus nerve. So that's important. Now, what's nice is they also have similar actions. So if we go down, or let's read this first. They're paired. So you have two superiors, two middles, two inferiors, one on each side. You can kind of see them here. Superior constrictor, middle constrictor, inferior constrictor. They're united in the midline, attached to the midline is the thing attached to the pharyngeal tube, the occipital bone. Now, they're going to narrow pharyngeal cavity, narrow pharyngeal cavity, narrow pharyngeal cavity. Their main actions: to constrict the wall of the pharynx while swallowing, constrict walls of pharynx during swallowing, and constrict walls of pharynx during swallowing. Their innervation is going to be all by vagus nerve. However, there's a slight difference with the superior compared to the middle and inferior. So superior, so they all get pharyngeal branch of vagus nerve, because they're all vagus nerve, and this is all pharynx stuff. And they get the pharyngeal plexus, but only the lower ones, middle and inferior, will get the external and recurrent branches of the laryngeal vagus, or laryngeal nerves of vagus, which makes sense because it doesn't branch off until a little bit later. So superior doesn't get it because it's still vagus there, and then later after it branches off, and you'll get the other two branches. They all have the same or similar insertions. Sorry, not insertions. Innervations. Insertions, the higher ones can get the pharyngeal tubercle. Lower one is the raphe. And then the last one gets the cricopharyngeal part. The last one also splits where it has two parts. You have a thyropharyngeus and a cricopharyngeus. And then the cricopharyngeus, which is technically the lowest part, that will be your upper esophageal sphincter. That's the thing where it closes when food is going down because you don't want GERD, which, if there's an issue there, you could get GERD, or you could get laryngopharyngeal reflux. Now, the difference between these two is GERD is more so we're talking about like lower throat esophagus stuff. So here you can get like heartburn, you can get chest pain. I don't know if like she'll want like specific details, but if there's like a stem or whatever, with GERD it's more like this is lower than the laryngopharynx or pharyngeal part. So this like lower part has to do with like esophagus. You'll get like heartburn and chest pain. Whereas laryngopharyngeal is more like silent when it comes to like, you don't really get like the heartburn or the chest pain. But because we're in the larynx pharynx part, over here you could get like hoarseness where your voice changes, which you don't really get with GERD. You could also like cough. This is higher up compared to the gastroesophageal. This is laryngopharynx. Also, the throat is like more sensitive than the esophagus, so less acid is like needed to damage this. So that's why you don't really want acid in here. The esophagus, although you don't want acid to be coming up, can handle it a little bit better than your throat. Okay. During a normal swallow, the thyropharyngeus will contract. Then the cricopharyngeus relaxes because you want things to go down. So thyropharyngeus, the top thing, will contract so it could go down. Then thyropharyngeus will relax because that's your upper esophageal sphincter, and you want things to go down the esophagus so they can go into your stomach, you can digest them, and whatever. If this coordinated relaxation does not occur, then you can have problems. You can get like a midline diverticulum, and then food can accumulate here. Then you get something called dysphagia, which is difficulty swallowing. Okay, now your longitudinal muscles. They elevate and they widen the pharynx and the larynx. So, they're all innervated, where is it? By the vagus nerve, except, and they love exceptions, the stylopharyngeus, which is by 9. So I would highlight this because anytime there's an exception, she could be like, all of these nerves are innervated by vagus except. Or she can be like, which of these is innervated by glossopharyngeal? She can give you all the other ones. And then just give you stylopharyngeus as an option. So stylopharyngeus originates at the styloid process temporal bone, inserts superior thyroid cartilage. This is important. It's the only cranial nerve 9-1. Shortens and widens the pharynx during swallowing and speaking. Now, salpingopharyngeus. The main actions are going to be the same for everything. So I'm going to just circle these in red. They're all going to do the same exact thing. Now, for salpingopharyngeus, from the cartilaginous part of the auditory tube blends with the palatopharyngeal muscles, and then this will get 10 because they all get 10. But it also gets the cranial part of 11. So there's a small part of a spinal accessory for both that and the next one. That's also why when we see later, when you split nerves, like the cranial nerves into which ones are sensory, motor, or both, there's also an exception for cranial nerve 11, where although it's only motor, because of this relationship between 11 and 10 and how it's like it hitches a ride with it or it's closer to it, it starts to have some effects, small effects that 10 would also have. And then palatopharyngeal, pharyngeus from the palate, so superior attachment is hard palate, lower pharynx, and then we said similar to the salpingopharyngeus with the innervation, and they all have similar actions. So innervation of the pharynx and pharyngeal plexus, this gets 9, 10, 11, and the autonomics. So we get branch of the vagus nerve, 10, spinal accessory, 11, glossopharyngeal, 9. It's posterior lateral wall of the pharynx, on the middle constrictor muscle phalanx, that's your pharyngeal plexus. It's also the primary, it also acts as the primary nerve supply for the pharynx and the soft palate. It's responsible for motor control, so something that's motor would be like swallowing. Then also some sensory and autonomic stuff. The pharynx is primarily innervated by the pharyngeal plexus, which we keep saying, and then 9, 10, and then some sympathetics. Vagus nerve provides the motor innervation to all of them, except, again, the stylopharyngeus. This was the exception we just talked about. Sensory innervation is shared between 9, 10, and V2. So cranial nerve 5 plays a role in here for sensory innervation, because cranial nerve 5 is mostly sensory, but it has a little bit motor as well, which is like the chewing stuff, like the muscles of mastication. Again, stylopharyngeus, innervated by 9. And then the cranial root or part of 11 also is involved in this because it joins 10. Okay. Larynx. This is your voice box. So it's a hollow tubular structure in the neck, critical role in breathing, producing sound, and protecting the trachea against food aspiration. It has your vocal cords. Remember in lab when we were talking about the vocal cords, the top one we said is the false vocal cord, lower one is true, and then in between this space is called the ventricle. And then we said F comes before T, so that's how you remember it. False first, then true. Open and close, you want to manage airflow and swallowing. This is to produce sound. So, the key difference between them, and I feel like you could definitely ask this, is the larynx is an organ. The pharynx is just like a space that has muscles around it. The larynx is an actual organ. So it has a skeleton, it has connecting membranes, discrete innervations, and vascular supply. So it's a complex valve pretty much, and it can regulate airflow. So that's a key difference between larynx and pharynx. Now, you have 9 cartilages in the larynx. They want to provide support. They form the skeleton of the larynx. They want to protect your airway. That's through the epiglottis. Voice production. So we'll see the arytenoid stuff. So arytenoid cartilage, move the vocal ligament, and this will allow like a change in the pitch and the volume of the sound. And then it's important for breathing as well. You have 3 unpaired and 3, or technically 6 total paired cartilages. That's where the 9 comes from. So, thyroid, unpaired, you only have 1. Cricoid, unpaired, you only have 1. Epiglottis, unpaired, only 1. And we've already seen the thyroid and cricoid ones, because when we were looking at the muscles, the cricothyroid goes from cricoid to thyroid. The thyroid cartilage, remember that's the one that has the Adam's apple. cricoid, we said that's the only like complete ring. It's below the thyroid cartilage. Remember, above it, above the cricoid cartilage and below the Adam's apple is where you can do a cricothyrotomy, where if you're trying to create an airway, you'll stab someone there. Then epiglottis, it's a leaf-shaped thing that closes off the larynx when you're swallowing because you don't want to aspirate. Now, these are paired, so you have 2 of this, 2 of this, and 2 of this. So that means you have a right one and a left one. The other ones, they're just one of it. They're just one of each. So your arytenoid cartilage, which is right here, is this entire pyramid-looking thing. So literally pyramid-shaped. It's on the posterior aspect of the cricoid because this is a posterior view of the larynx. This is your cricoid. This is your thyroid. This is your Adam's apple. So your arytenoid is on the posterior of the cricoid, so we can see it only from a posterior view. And it's important for speech, because remember when we just said this right here, voice production, your arytenoid cartilage do that. What they do is they connect the vocal folds and they move them. If you look at your corniculate cartilage, it's this top part, or it's technically at the apex of the pyramid, which is your arytenoid cartilage. So small, elastic, articulates with the apex of the arytenoid cartilage. So it'll provide like some support to the aryepiglottic folds. Aryepiglottic folds, so that'll have a role in both sound and swallowing. So it's important to protect that because you don't want these things to get mixed. And then cuneiform, so you can't really see them here because it's anterior to the corniculate cartilages. So if you want to see something that's in front of this, you won't be able to see it because from the other view, this is blocking it off. So it would be behind this, or posterior, and then in front or anterior to this. So, I mean, we would need like a side view, technically, a lateral view to see that stuff. But all it does is just, so this one provides support, this one strengthens the lateral aryepiglottic folds. Now, extrinsic muscles of the larynx. So, this was lab stuff. We've talked about this so many times. You have the suprahyoid, elevate the hyoid. Infrahyoid, depress the hyoid. And then all the different muscles that we talked about, whatever. I think by now we have this stuff down. Now, muscles of the larynx, glottis. So, these, kind of like the pharynx stuff, all have similar blood supply. So this applies to all. It's superior and inferior thyroid arteries, which makes sense because that's where your larynx is, around that range. And then the innervation is all recurrent laryngeal, but I'm going to star this because one of them is not. And that one is going to be your cricothyroid. That's innervated by the external branch of your superior laryngeal nerve. So, let's run through them. Lateral cricoarytenoid. And you can see them here. So this is lateral cricoarytenoid. This is both transverse and oblique. This is posterior. And they're all going to do different things depending on what we want with our vocal cords. Or if we're swallowing or anything like that. So, lateral cricoarytenoid originates at the arch of cricoid cartilage, with the crico, and then inserts at the muscular process of the arytenoid cartilage. This is going to adduct the vocal folds. For the actions, Paulina has a good summary here. So this is really good. That tells you which ones are your adductors, abductors, sphincters, and tensors. So if you memorize it this way, it's easier to memorize this way instead of just reading about each one individually. Transverse arytenoid is going to originate at the arytenoid, and then it's going to insert opposite the arytenoid cartilage, same innervation, same blood supply, and this is going to close the rhemoglottides, intercartilaginous portion. Then you have your posterior cricoarytenoid, the only abductor, so that could definitely be a question. because she loves exceptions for the millionth time. It works on the actual folds, posterior surface of the lamina, cricoid cartilage, whatever, same innervation, same blood supply. This is going to abduct, which is key difference. Cricothyroid, we already talked about, not innervated by RLN is the recurrent laryngeal nerve. SLN is superior laryngeal nerve. So the innervation is the external branch of the superior laryngeal nerve, not recurrent laryngeal. Originates at the anterior cricoid, inserts inferior border of the thyroid and its inferior horn, and this is going to lengthen and tense vocal ligaments, and then blood supply, same for all again. Thyroid, same innervation, same blood supply. We'll run through the actions after. Posterior aspect of thyroid cartilage, insertion muscular process of retinoid, and then the vocale, which is the vocal process, or originates the vocal process of retinoid cartilage, inserts the vocal ligament, same innervation, same blood supply. This is going to be relaxing your vocal ligaments. So the summaries of the muscles, your adductors, we have multiple. So it's the lateral cricoretinoid and the transverse. The abductors, only one, which is posterior cricoretinoid. Then you have a bunch of them that do sphincter roles. Transverse will do both sphincter, acts as a sphincter and as an abductor. And then the other ones just have one role. And then your tensors are your thyroretinoid and your vocalis. Now, laryngeal innervation. So, mostly recurrent laryngeal. Obviously, we said we have the exception, which is the cricothyroid, which is the external branch of superior laryngeal. So, this is the motor stuff here. For sensory, we have internal laryngeal and recurrent laryngeal. Above the vocal folds, so superior surface, is going to be internal laryngeal. Below or inferior surface is going to be recurrent. So this is how we're going to remember this. If you remember the IRS, so this top one is just sensory. This bottom one is just motor. R is in the middle, so it gets both sensory and motor. So internal laryngeal is just sensory. Superior laryngeal is just motor. But recurrent laryngeal is going to do both sensory and motor. So that's why it's in the middle. It does both. Now, this is also nice because in this case, your I is above your R. So the I is superior and your R is inferior. So that's how you know that the I, or the internal laryngeal, does the above or superior surface of the folds, of the vocal folds. And then recurrent is inferior. And then if you want to remember which muscle is innervated by the S, or superior laryngeal, we're talking about like motor. Think of like cars. So a car, so cricothyroid, CR. So cricothyroid. I don't know if that helps. But yeah, if you remember IRS, it'll tell you which one's sensory, which one's motor, which one's in the middle that does both. It'll let you know which one's superior and which one's inferior. And then you can remember that the exception is cricothyroid, which is the one that's only motor or superior laryngeal nerve. Okay. Now, the nice part about the rest of the stuff is a lot of the stuff we've seen in neuro, we've seen in lab. I feel like we've talked about cranial nerves in like every single class. So some of this stuff is going to be reviewed. Some of this stuff, if you know the lab stuff, will make a lot of sense. We have efferent and afferent fibers. E is going to be motor. Afferent is going to be sensory. So when we're talking about special senses, so whether it's motor or sensory, are going to do with the head and neck region. and I'll explain that in a second. So, motor fibers, efferent. If it's general and it's somatic and it's motor, it's just motor fibers to the voluntary striated muscles. If it's special, it has to do with head and neck. So, these are the tissues that are from the pharyngeal arches in the embryo. So that's more embryo stuff. Marvin's guide is beautiful. It's like 15, 16 pages, but it goes through everything. It explains the pharyngeal arches and which one of those muscles of mastication, whatever. I believe this is the first arch, but I'm put a question mark, so double check me on this. This has to do with muscles of mastication. So muscles, because this is motor, in the head and neck region, because your muscles of mastication are in your cheek. So it makes sense that this is special somatic efferent. Anytime you say visceral, visceral has to do with an organ. So we have autonomic fibers that transmit to smooth, cardiac, glandular. We're talking about organs. Now, for sensory, general, somatic, afferent. This is just general sensation, not head and neck stuff because it's not special. So this is your touch, pain, pressure, heat. And these are some of the cranial nerves. We'll go over this stuff in a bit when I do like the mnemonic and whatever. And then general, visceral, afferent. So it's sensory, but now visceral, sensation from viscera or organs. So now, pharynx, larynx, trachea, bronchi, lungs, heart, GI, carotid body and sinus, which is the stuff we talked about in the internal carotid, common carotid, whatever. When we say special, now we're talking about the senses in the head and neck. So, smell and taste are going to be special visceral afferent. Vision, hearing, and equilibrium or equilibration are going to be somatic. The reason these are split into two is more like an embryological thing, because these are technically ectodermal, and then these are technically endodermal. But if you want to like kind of remember which ones are somatic and which ones are visceral, S comes before V, so the stuff that are higher up are S or somatic. So your eyes, your ears, so vision and then hearing and equilibration. Eyes and ears are higher than your nose and mouth. So eyes and ears, kind of nice because they're both E as well, are somatic. So these are your E's, eyes, ears, somatic. And visceral is going to be your nose and mouth. But these are all special sensory, so special afferent. Only thing the difference is if they're somatic or visceral. Okay, now cranial nerve entrances. I went through all this in the lab stuff, but I'm gonna quickly skim through it. So first, this is if you cut the skull where you can split the top away from the bottom half. This is the cribriform plate where the olfactory nerve will come through. The tip is like the olfactory bulb, but this is the olfactory nerve. It goes through the cribriform plate. So first cranial nerve, you start at the crib. So cranial nerve 1, cribriform plate. Cranial nerve 2, oh my god, this color choice is awful. Optic nerve goes through the optic canal. You also see an artery going through there as well. That's your ophthalmic I don't know who decided to put an H in ophthalmic, but that's your ophthalmic artery. Then you have your superior orbital fissure, which is like under if you go in there. And if you follow it around, like you put a pipe cleaner lab, you follow it around, it literally goes to the top of your orbit because it's superior orbital. In your superior orbital fissure, you get, so in SOF, you get cranial nerves 3, 4, V1, so only the first part of 5, which is your ophthalmic, not your maxillary or mandibular, which would be V2 or V3, and 6. So 3, SOF, 4, SOF, V1, SOF, and V2, all SOF. It's nice because these are all like eye stuff, and they're going to the superior orbit, or where your eye is. So 3 is oculomotor, motor to your eye. It'll do medial rectus, inferior oblique, superior rectus, and inferior rectus. So 3 will do middle rectus, superior rectus, and inferior oblique. 4, also motor for the eye, will do superior oblique. And then 6 will do lateral rectus. 3 also does your levator palpebrae, which elevates your eyelid. If there's damage there, you get ptosis, which is droopy eyelid. And then it's partial if it's Horner syndrome, so sympathetics are affected. And then it's complete if it's cranial nerve 3 damage. So you get complete ptosis. Sorry, I do this thing with like, I just start saying everything. But we'll also see this in a bit. After that, you have your, so you have 3 openings in the skull. So you see how this is cranial nerve 5 or trigeminal? The V1 is going through your superior orbital fissure. V2 is going through this first opening, which is rotundum. Foramen rotundum. V3 will go through foramen ovale, literally oval shaped. And then in this tiny opening right here, this is your spinosum, foramen spinosum. The main thing that goes through here is an artery called MMA, or middle meningeal artery. And then 7 and 8 are going through this opening, which if you follow through, kind of goes to your ear. So it's internal acoustic or auditory meatus. And then 9, 10, and 11 all go through the jugular foramen. So this, and this go through the jugular foramen with the internal jugular vein. And then hypoglossal nerve goes through hypoglossal canal, which is like, so this whole thing's the foramen magnum, literally big whole foramen magnum, big, magnificent. So it's like right before you get to the foramen magnum, so it's like more lateral. And that's all that stuff here. So you can group them together. So these 2 are together, these 3 are together, and that's there. Okay, now the carotid canal. You can only see the carotid canal on the bottom of the skull. So it's in the lab stuff, but if they turn the skull around, you can see the carotid canal on the inferior or bottom portion of skull. And we said this when we were talking about the common carotid artery, internal carotid, external carotid, but this is where the internal carotid goes through. Then for specificity, exits the petrous part of the temporal bone to the middle cranial fossa near the posterior lateral boundary of the foramen lacerum, which is another opening of the skull, which is right, can't really see it, but it's like in like there. So the ICA like runs anterior to it. Okay, foramen magnum, big opening in the skull, large oval opening, base of the occipital bone. It's the main conduit between the brainstem and the spinal cord. So you have your medulla there, vertebral arteries, because those are coming up through the transverse foramina. You have spinal arteries, and then cranial nerve 11 also runs through there. Now, these are what they do. So, to remember the cranial nerves, also this was lab stuff, but if you remember, ooh, to touch and feel very good vaginal, then you go AH. So again, I didn't make this dirty mnemonic. It was my undergrad human phys professor, but that's how I remember them. So olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory or spinal accessory, and then hypoglossal. And then these are their functions. Now, to remember which ones are sensory, which ones are motor, and which ones do both, you remember, some say marry money, but my brother says big brains, this is customizable, matter more. So, first one is S, just sensory. So is the second one. 3, 4, 6 are motor. 5, 7 do both, sensory and motor, and then you can keep going down. 8 is sensory. 9 and 10 are both. 11 is motor, and 12 is motor. With the eye stuff, the main eye stuff are 2, 3, 4. Wow, I can't count. 4 and 6, and then part of 5 because it's V1. But if you notice, only 2 is sensory. So vision loss is most likely going to be, or it's going to be optic nerve, because that's the only sensory one. But if your eye can't move in a certain direction, then it's going to be 3, 4, or 6, because those are responsible for motor or movements of the eye. So hopefully that makes sense. So for 2, you would get blindness, visual field deficits. But for 3, you get like a down and out eye, so it can only move in a certain direction. 4, you would get difficulty looking down, for example, because your eye can't move in a certain direction. 6, you have an ability to abduct the eye. So hopefully that makes sense. Okay, and then now, this is what I was talking about earlier with cranial nerve 11 and how it's a unique one because it runs with 10. So if we go through our some say marry money, but my brother says big brains matter more, from 1 to 12, the sensory ones, so group 1 is your special sensory. These are all special, technically, because like they're in the head and neck, are 1, so 1, 2, and 8. So that's how you group them. So this entire thing, this entire chart, if you just remember this mnemonic, will help with that. Now, for motor, we have 3, 4, 6, and 12. 3, 4, 6, 12. 11 is the exception. Because remember how it hitches a ride and does some stuff with cranial nerve 10? So now your branchiomeric, remember branchio for both, B for B, M for M, and then sensory for S, whatever. I don't know why I circled it in blue when I was doing red. Oh, sorry if that was confusing. Okay, so for both, it's 5, 7, 9, 10, 5, 7, 9, 10, but also 11. Because, again, it has that relationship with 10. It also has to do with, like, embryologically, where it's located with, like, the arches and whatever. Because if you follow them down, 5 is first arch, 7 is second arch, then it's third arch, then it's fourth arch, and 11 gets both fifth and sixth arch. So it's also an embryological thing why it's like that. Okay, and this is a good picture that shows all this stuff. Now, reflexes. Again, more neural stuff, but when you blink, the sensory afferent part is V1. Sensory or afferent, V1. Motor or efferent is cranial nerve 7. So the cornea, sensory innervation by V1. So if someone, the way they test it is they'll put like they'll put something, obviously like something that doesn't hurt you, like near your eye on the cornea so that you blink. So feeling it, the sensation part is V1, but the actual blinking is cranial nerve 7. And the muscle innervated by cranial nerve 7 is orbicularis oculi. This is the lab stuff. It's the muscle around the eye for blinking. For afferent, it's the long ciliary branch of V1. Now, for accommodation reflex and near response. So, when something gets closer to you, so remember, sensory is only cranial nerve 2, because we said that's an only sensory one. The motor one in this aspect is oculomotor, because here we're doing stuff with the pupil, with the lens, and then specifically muscle-wise, it's with the medial rectus. If something is far away and now it gets closer to you, when it gets closer to you, you do 3 things. You converge. So eyes move towards each other. If both eyes are moving towards each other, they're both moving medially. If they're both moving medially, it's your medial rectus that's doing that. Your medial rectus is innervated by your cranial nerve 3 or oculomotor. Remember, the only 2 exceptions were SO4 and LR6. So superior oblique, it's 4, which is trochlear. And then LR6, lateral rectus, gets 6, which is abducens. The rest all get 3. That's like a side note. So what happens is your eyes converge, they constrict, which makes sense why cranial nerve 3 does it, because that's a parasympathetic response. When someone shines a light in your eye constricts. And then your lens actually gets thicker or fatter. So the way you want to think about this is, if someone is far away, they look smaller, skinnier. But if they get closer to you, they look bigger, fatter, thicker. So the lens will get thick for a near object. Your ciliary muscle will contract, because you don't need the full eye to see someone that's right in front of you, so it'll contract. But now if we're looking at something that's farther away, the lens can get thinner. The person looks thinner, right? But the ciliary muscle will be relaxed, because now we need to expand that part so we can see something that's so far away. We kind of need to use more of our eye if you want to think about it. So sensory part, optics only sensory, cranial nerve 2. The efferent part is oculomotor, but also V1. Okay, now the light reflex. When someone shines a light on your eye, the sensory part, you seeing the light, is optic nerve. Your pupil constricting, it's a motor thing. So oculomotor, because oculomotor is only motor. Optic is only sensory. So that's why if you know the cranial nerve stuff, what they do will start to make sense. So it's involuntary. You don't tell your eye, hey, constrict because we see light. I mean, if you do, what is going on? Okay. So pupil constricts in bright light and then dilates in low light. You're protecting the retina. You're managing light intake. If there's a lot of light, you don't want to make your eye bigger and stab your retina with all this light. Afferent, optic nerve, sends signal to midbrain, synapse in both the right and left Anterior Westfall nucleus, which is the parasympathetic one, cranial nerve 3. Again, this is all neural stuff. And then it'll make both pupils dilate or constrict. So you shine a light in the right eye. Your optic senses it. Your oculomotor will make it constrict, but it also makes the other guy or the other eye constrict. And then vice versa. Okay, now, if you have... Oh wait, let's do this part first. So, the accommodation reflex, pupillary reflex, fibers are carried by post-ganglionic parasympathetic via short ciliary nerves to sphincter pupillae and ciliaris muscle. I think this is also mentioned again, but the short ciliary nerves will help constrict the eye. So the sphincter pupillae. But for the dilator, you would use both short and long. So think about your eye is bigger, or your pupil is bigger, so you would need more things. So this uses both short and long. I believe this is also mentioned again in a different section. So smaller is just short. For dilator, it's both short and you get the long as well. And then we talked about all of this. So oculomotor is going to do all of these. Not the superior oblique, not the lateral rectus, but the rest, which is this stuff, get 3. An important one is this one, because this elevates the eyelid. If you have damage there, or damage to cranial nerve 3, now this thing is going to drop and you get ptosis. If it's Horner's syndrome, it's partial ptosis, because your sympathetics are affected. And one of the sympathetics controls an eye muscle that plays a role in elevation. But if your oculomotor nerve, which is cranial nerve 3, is damaged, then you get complete ptosis. The entire eye is droopy. So cranial nerve 3 injury, the only muscles that are working are lateral rectus and superior oblique. So lateral rectus takes the eye laterally. Superior oblique, the obliques are opposites, remember? So inferior is going to elevate, superior is going to depress, unlike the rectuses, which are just normal. So this is going to depress the eye. So now your eye is going to be down because this depressed it, and laterally. So you get the down and out, because these are the only 2 muscles working. The others are damaged. Down and out, because 4 and 6 are overcompensating. You get the complete ptosis because this is cranial nerve 3 damage, unlike Horner's syndrome. And then you get unopposed sympathetic because your parasympathetics are damaged. So only sympathetics are working now. You get double vision. Obviously, if you have one eye that's down and out and the other is normal, your eyes aren't looking at the same thing. So you have a misalignment of eyes, diplopia, which is just double vision. And then anhidrosis, you can get lack of sweating and tears. That's more so seen in Horner's syndrome because your sympathetics are gone. So if you do see it in this, it's less of anhidrosis, but I don't know if she'll ask that specific thing. Okay. Now, for the tongue, we have anterior 2/3 of the tongue, and then posterior 1/3. You can have general sensation, which is just you feel something on your tongue. But then the special sensation is taste. So for anterior 2/3, it's different. Your chorda tympani, which is part of cranial nerve 7, will do taste. Your lingual, which is part of cranial nerve 5, specifically V3, will do just sensation. The way you remember it is CHO, you taste chocolate. So chorda tympani is for taste. So the other one, which is lingual, is your sensation. And lingual, just remember, it has to do with tongue. For posterior 1/3, it's nice because both of it, taste and sensation, is a glossopharyngeal. So that one's easy. But this is an important difference. Okay, what do we have here? Trigeminal is going to have 3 parts. First part is going to be ophthalmic. Then it's going to your maxilla. Awful color choice. So maxillary, and then the lower part, mandibular. So first is ophthalmic. When we say V1, that's what we're referring to. V2 is maxillary. And then V3 is mandibular. For taste, we talked about the chorda tympani. There's also a nerve called the greater petrosal nerve, which plays a small role, I would say, in taste. So it's a nerve also facial, carries parasympathetic for tear and mucus production, some taste fibers. So not a huge or significant role, but it does play a role. So chorda tympani is the one that we said is the anterior 2/3 of the tongue, passes through the middle ear, carries taste sensations, contains parasympathetic fibers, submandibular, sublingual, whatever. But they both carry taste fibers. The difference is greater petrosal obviously only carries some taste fibers, and it's mostly like from the soft palates. This is like roof of the back of the mouth. But chorda tympani does the anterior 2/3. The difference between, so we have a greater petrosal nerve and a lesser petrosal nerve. These come from different, just like how, remember, we had superior thyroid and inferior thyroid, and they all came from like different arteries branched. These come from different cranial nerves. So greater petrosal comes from cranial nerve 7, or facial. Lesser comes from cranial nerve 9, or glossopharyngeal. The way to remember it is we're going to remember the Ronaldos. So the greater Ronaldo is CR7, the Portuguese one. The lesser Ronaldo is R9, the Brazilian one. They just call him R9 because Ronaldo, he was number 9. Cristiano Ronaldo, number 7. So the greater Ronaldo is 7, so greater petrosal 7. Lesser petrosal 9. Beautiful. Okay. So this has to do with the hypoglossal nerve. So think of the hypoglossal nerve as something that pushes your tongue. So when your tongue is straight, it's because this hypoglossal is pushing it and this is pushing it at the same time. If this is damaged and it stops working, then only this is pushing, so now your tongue deviates this way. So tongue deviates towards the lesion. So towards lesion in hypoglossal nerve. If you remember neuro, the uvula was the opposite. Uvula was away from lesion. But it's not on here, so we're going to ignore it. Okay, now, the 4 parasympathetic ganglia. We have ciliary to the eye, pterygopalatine to the lacrimal gland, submandibular to submandibular gland, and then otic to the parotid gland. I'm going to try to explain these using mnemonics. I hope these help. I think if they're going to ask anything about them, it's going to be like the differences between them. So hopefully this helps. These are locations of them. So you have ciliary right here. You have pterygopalatine right here. Pterygopalatine is kind of where like all of your bones meet, like your sphenoid, ethmoid, maxillary, all that stuff. I think frontal as well. And then otic is right here, and submandibular is right here. So to remember them in order, you're going to remember eye, tears, drool, spit. So ciliary to eye. I'm talking about lacrimal here, so it's tears. Then drool, submandibular, and then spit, otic to parotid gland. For the sensory root, for all 4 of these, highlight this, star this, whatever, sensory root is always trigeminal. So sensory for all 4 it's one of the V's. So it's going to be V something. And since we have them in order, we're going to remember for sensory, for the first one, V1, specifically nasociliary. Second one, V2, main trunk of V2, so we're talking about maxillary. Third one, V3, which is lingual, and then we only have 3 V's, so the last one also has to be V3. So it goes in order. If you remember eye, tears, drool, spit, it's V1, V2, V3, V3. Now, this stuff is kind of annoying because there's a lot to memorize, which is how I remember that it's also annoying that the mandibular nerve does not go with the submandibular. It actually goes with the otic to parotid. So the last two are V3, but this one's specifically lingual, and this one's specifically mandibular. It would have been nice if mandibular went with submandibular, but it doesn't. Okay, now that's for the sensory stuff. For the sympathetic stuff, so for the ciliary to eye, it's carotid plexus, which is around the ophthalmic artery. For the second one, it's deep petrosal nerve off the internal carotid plexus. Then it's the sympathetic plexus on the facial artery, and then it's the sympathetic plexus around the middle meningeal artery. So this is how I remember this one. So let's write these down. Eye, tears, drool, spit. Then now we're talking about, so blue was sensory root, because they all have a motor root, a sensory root, a sympathetic root, and a distribution root. So hopefully this helps differentiate all these, or helps you remember them. So your mom tells you to eat this carrot. In this case, obviously the carrot is your op, because you don't like carrots. And you don't. So she deeply punches you. She gives you a deep punch in your face, MMA style. So the I one is your carotid plexus, and carrot is your op because it's around the ophthalmic artery. She deeply punches you. Deep petrosal nerve. The third one, facial. The last one, MMA style, middle meningeal artery style. Hopefully this helps. If you just want to memorize them, you can memorize them, but this actually kind of helps you remember them. And then I have one more mnemonic. I know, I'm sorry. So the last one is the motor one. So for the motor one, again, eye, tears, drool, spit. For motor, so when we're thinking of motor, like you're moving around, you're active because you're trying to lose weight, right? So you start this weight loss journey. I'm sorry that these like turn into stories, whatever, but right away you lost 3 pounds, and everyone goes great. But what do they tell you that you obviously can't have? They tell you chocolate less. So 3 pounds, great. Chocolate needs to be less. So the motor for the I one is cranial nerve 3. And these are also all preganglionic parasympathetic, by the way. The way I remember that this stuff right here was sympathetic is because if someone's getting punched in the face, you're sympathetic towards them. Or empathetic if you want to be mean and whatever. But you're sympathetic, so that's how I remember if someone's getting punched, sympathetic. Then the motor one is the person trying to lose weight because they're moving. But motor, we said, is 3. So cranial nerve 3. The second one, the tears one, is great because it is greater petrosal. Remember we said this is branch of 7 because the greater Ronaldo is CR7. The third one, the motor, is chorda tympani. This is nice because we already used chocolate as the thing to remember that it does anterior 2/3 for taste because you taste chocolate. And then the last one for motor is less because it's lesser. This should say petrosal. So lesser petrosal nerve, which we said is 9 because that's your R9. And they're all preganglionic parasympathetic, so no differences between them. So I hope these were at least like somewhat helpful. If not, it's okay. And then this is what I was talking about when we were talking about the So for the ciliary to I1, we were talking about the short versus long. The short ciliary will do, so that's parasympathetic because you're making the pupil smaller. So if you're making it smaller, you just need the short ones. But if you're making it bigger, so dilating it, you need both short and long. So that's the key difference between those two. It's for sympathetics, dilating the eye. And then this was nasociliary branch. If you remember the branches for V1, they're NFL. So NFL, it's nasociliary, frontal, and lacrimal. Those are all branches of V1, or ophthalmic of trigeminal, because it's V1. Frontal you should know because that was in the lab stuff. The one that subdivides into supraorbital, top of orbit, and then the medial one is supratrochlear. And the way you remember that is because it's above the trochlear nerve, which is the superior oblique muscle. So that goes more immediately. Okay, after this, again, a lot of this stuff is like neural stuff, so I'm kind of going to skim through this stuff, but let's do it. So dural venous sinuses, endothelium-lined spaces between the periosteal and meningeal layers of the dura. You have large veins from the surface of the brain empty into these sinuses, and then they drain deoxygenated blood from the brain into the internal jugular veins. Because we're taking deoxygenated blood down, the arteries are going to bring us oxygenated blood back up. So Phelps Cerebri celebrates the two cerebral hemispheres. Separates your right and left. Cerebral hemispheres. Cerebelli is for cerebellum. So it's going to separate your right and left cerebellar. Tentorium cerebelli is a tent above your cerebellum. So this is your cerebellum. We have a tent because cerebellum is literally like shaped like this or whatever. And then above is your cerebrum or your cerebral hemispheres. So that separates the two. Diaphragm cella or celli is the roof of the pituitary gland. And then these are the folds. This is more lab stuff where you'll have your superior sagittal sinus, inferior sagittal sinus. You have a straight sinus, confluence of sinuses, and then later you'll get like transverse, sigmoid, and then drains into internal jugular vein. And all of this stuff kind of goes in that order. So transverse will go into sigmoid into internal jugular. Where's greater petrosal? Greater petrosal should be into superior petrosal into transverse, inferior into sigmoid, and you can kind of see this here. So, superior sagittal sinus, inferior sagittal sinus, straight sinus, transverse, and then now this S-looking thing is sigmoid. And then eventually this is going to drain into the internal jugular vein, which you can't see in here. And then you can see how the superior, where is it? So these are your petrosal sinuses. The superior one will go into transverse first, and then transverse will go into sigmoid, whereas the inferior one will go straight into sigmoid. So those are a few differences in there. But again, that's more like lab stuff. So bridging veins, this has to do with like ruptures, strokes, all that stuff and whatever. So bridging veins drain the venous blood from the cerebral cortex to the superior sagittal sinus, and in doing so, they bridge the subdural space. So if these explode or something bad happens here, you could get a subdural hematoma, which is different than an epidural hematoma. Epidural hematoma has to do with an artery. Specifically, specifically the middle meningeal artery, the MMA. This subdural has to do with the veins, specifically like the bridging veins. The difference between bridging veins and emissary veins, so emissary are valveless. They connect the intracranial venous sinus to the extracranial venous sinus. They go through the foramina of the skull, And then they have roles in like equalizing pressure, cooling brain, transmitting extracranial infections. But they go from outside to inside of the skull. So they go through the skull. That's important because this is a route for infections. Because we have something called a cavernous sinus that could be damaged in this case. Cavernous sinus. And that's this thing right here. This huge sinus. There's this like imaginary triangle in the front of her face where if you scratch something or try to pop a pimple on like the middle part of like your nose or lips or whatever, an infection can go back to this cavernous sinus. It could cause many problems because you have cranial nerves 3, 4, V1, V2, and 6 that all are in there. Even like your internal carotid arteries around there. So a bunch of things can get damaged. So that's why they tell you like don't pop pimples, especially in like that dangerous triangle of your face. So emissary veins outside to inside the skull. Bridging veins stay within the skull. And that's the key difference between them. Because we're going from cerebral cortex to superior sagittal sinus, but we're still within the skull. So we stay inside the skull. You're just going from brain to dural sinuses. Whereas emissary passes through the skull. You're going extra to intracranial dural sinuses. Epidural hematoma, we said, has to do with like an artery caused by trauma. If you get a blow to the pterion, which is like the lateral, whatever part of your skull, you can get laceration to the middle meningeal artery. So epidural, above dura, below skull. So between the skull and dura. Subdural, the one here, was below dura, so above your arachnoid, because it goes dura, arachnoid, pia. I can't even spell anymore. I'm exhausted. Okay. Pterion's a crucial anatomical landmark, side of the skull, which is what we just said. That's what I was saying, where frontal, parietal, temporal, and sphenoid bones meet. That also kind of helps when we're talking about the pterygopalatine ganglion, which is one of the 4 parasympathetic. You had otic, pterygopalatine, blah, 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 whatever. That was like the location of it. And it's important because it's a weak part, the weakest part of the skull. So you can get damage there to the middle meningeal artery, and you can have kind of like stroke-like symptoms. So this is important too, because this is unique. You get a lenticular shaped, kind of like moon-shaped-ish, and it does not cross suture lines. Again, this was neuro stuff. So you can get unconsciousness, lucid, you'll have like a lucid period, and then you can get into a coma. Subarachnoid hemorrhage, this is dangerous because what's in your subarachnoid space? Your CSF. And your CSF has a long route, pretty much goes through a bunch of places. So now if you're bleeding there, now your blood is going to those same places. So bleeding accumulates in the subarachnoid space. A ruptured aneurysm of a cerebral artery can cause this. And then now you get a sudden, severe headache. And the key stem is someone goes, this is the worst headache of my life. If they say that, it's a subarachnoid hemorrhage. Then you have all these things, nausea, vomiting, stiff neck, decreased consciousness, seizures, focal neurological deficits. This is obviously serious. And then intracerebral hemorrhage, now we're within the cerebrum. This is life-threatening, fatal type of stroke. When a diseased or ruptured blood vessel causes bleeding inside the brain parenchyma, now everything up there is like getting clipped. So your basal ganglia, cerebellum, balance stuff, brainstem. Your brainstem, I mean, if your medulla, which has like your respiratory stuff and whatever, is gone, you're not going to be able to survive this. So severe headache, weakness, vomiting, loss of consciousness, but then this is like immediate. This is like an immediate medical or emergency medical care is critical. Cavernous sinus, we just talked about this. This is the key thing. 3, 4, V1, V2, and V6. I don't know if they'll ask this. Sometimes they do. Where it's like, what's the difference between what's in your cavernous sinus and what goes through your superior orbital fissure? So we said cavernous is 3, 4, V1, V2, and 6. Remember, for superior orbital fissure, what goes through there is 3, 4, V1, and 6. So this is technically the difference between them. But paired, sponge-like venous structure, base of the brain, we saw in that picture above. drains the blood from the brain and face. It's on either side of the sella turcica, which is like this thing right here. Critical dangerous pathway for blood from eyes and brain. That's like the danger zone where you don't want, like, danger triangle, nose and lips. If they go back to the sinus, now they go everywhere and they damage a bunch of things. So blood supply to the brain, again, also lab stuff. So if you understand this lab stuff, you'll understand this. But the way it goes is you have these two vertebral arteries. The branch of the vertebral arteries is this pica. This is vertebral. Then you have your basilar artery. Say bas. Your basilar arteries can give you a bunch of branches. You have AICA or ICA. You're going to have labyrinthine, lab. You're going to have the little spider webs, which are your pontine. These little arteries all going around like spider webs are your pontine. And then you're going to have two final branches. So this is superior cerebellar artery. And this last one here, which is the last branch of basilar, actually, let's do this, is your PCA, but the C is cerebral, so posterior cerebral artery. Then you have your ICA, which is this thing popping up at us. That's ICA. And then that's going to give MCA, middle cerebral, and then ACA, anterior cerebral. You also have an anterior communicating artery between your two ACAs. Again, this is lab stuff. I just want to make sure that I include everything here, though. And then your PCA is between your posterior communicating artery, not PCA. When I said PCA, I'm talking about the cerebral. This is between your internal carotid artery and the actual PCA. So that connects internal carotid artery to posterior cerebral artery. So that's your blood supply. If you notice here, you get this like circle-looking thing, and that's your circle of Willis, all like within here. So this allows, if there's damage to one of these blood vessels, to at least try to make it up with the other vessels around. So the anastomose for that reason. So brain is supplied by two main arteries. It's the internal carotid and the vertebral. The vertebrals are going to eventually become your basilar. So they connect to the base of the brain, the anastomose, circle of Willis. Arterial supply, two main systems. So the anterior circulation, so this whole front part, is the internal carotid, because that gives you your ACA and MCA. ACA, medial surface of the brain, because it goes anterior. MCA, lateral surface. MCA, lateral. ACA, medial. Also with the names, when we say pica, it's posterior inferior cerebellar, because this is your cerebellum. ICA or ACA, anterior inferior cerebellar. So cerebellum, cerebellum, superior cerebellum. So these two do inferior cerebellum. This does superior cerebellum. Then we want the cerebrum, this entire thing above the cerebellum. So we have a posterior, middle, and anterior. So if you're going from posterior to anterior, first you do your cerebellum, posterior, or pica, ACA, superior cerebellar, and then you do your cerebrum, PCA, MCA, ACA. Okay, so posterior circulation is for the cerebellum, and then brainstem, hemispheres. We're in the back, so occipital, two vertebrals will join to give you your basilar. The last branch of the basilar is your PCA. Circle of Willis, this whole thing. Awful color choice, this whole thing. Whatever. Patagonal vascular structure, base of brain, connects anterior and posterior systems. Safety mechanism, allows blood to be redistributed if one main artery is blocked. Key component including anterior cerebral arteries, which are these. And the anterior communicating is what connects them in the middle. Internal carotid arteries, these things that are poking out at us. posterior cerebral arteries, and posterior communicating. So posterior cerebral, which is the last branch of basilar, and then posterior communicating. So yeah, key thing is pica is a branch of vertebral. Ica or aca is a branch of basilar. So that's important to differentiate. And then ACA and MCA, so anterior cerebral and middle cerebral, are a branch of internal carotid, but PCA is still a branch of basilar. And then we already talked about the sinuses. So you have dural venous sinuses, blood drains the channels between the dural matter, so dural venous sinuses. The major ones are the ones we keep seeing in lab: transverse, inferior, straight, superior sagittal, inferior sagittal, straight, transverse, sigmoid, and then eventually after sigmoid, it goes and drains to the internal jugular vein, which will combine with everything drains into there, which will combine with the subclavian, give you your brachiocephalic, right and left brachiocephalics, become your superior vena cava. Horner syndrome, we already talked about this. You get ptosis, meiosis, and hydrosis. This is not damage to cranial nerve 3, or else that would have been complete ptosis. This is damage to the sympathetics. So parasympathetic still work. So here it's partial ptosis. And then sympathetics are damaged. So if no sympathetics, no sweating. Think of like sympathetics as like your fight or flight, you're running, you're sweating, whatever. So you get anhydrosis. And then meiosis because it's a constricted pupil, because your parasympathetics constrict. If your sympathetics are damaged, we can't get a bigger eye or wider pupil, whatever. So it's constricted. Orbit, lacrimal gland is at the top, outside. So supralateral aspect. So tears start here, they go around like this, and what brings them this way is blinking. Then they go into here. So supralateral aspect of orbit, they're under autonomic innervation. Postganglionic parasympathetic will be from the internal carotid plexus via the deep petrosal nerve, which we said comes from cranial nerve 9. Sorry, that was lesser, not 9. Deep petrosal, I believe, is still 7. But double check me on that, so I'm not going to write that down. Preganglionic will stem from 7, travel via the greater petrosal nerve. What is ptosis? Ptosis, droopy eyelid. That's because where's the levator palpebrae superioris? It's damaged. And then if it's partial ptosis, it's Horner's syndrome. If it's complete, it's cranial nerve 3 damage. So Muller's muscle, I believe this also has another name. It's like tarsal or superior tarsal muscle, assists in lifting the lid. So if this is damaged because your sympathetics are damaged, then you get Horner's syndrome where it's only partial. But the main one is levator palpebrae. If this one is clipped, then you get complete ptosis. We already know this stuff. So lateral rectus is going to abduct, medial is going to adduct, superior rectus elevate, inferior rectus depresses. Then the obliques are flipped. They're opposites, right? So inferior is going to elevate, superior is going to depress. This elevates the eyelid. And then we know all this stuff because it's SO4. Let's write it next to it. So LR6, 6 for LR. SO is 4. And then the rest to get 3. Ciliary muscle, this is adjusting the whatever of the eye, also 3, also 3. So 3 does everything pretty much except for LR6 and SO4. If abducens is paralyzed, you can't look laterally. So your eye is going to be medially deviated. So you get internal strabismus because it's more medial, and then eye turns inward, esotropia. Now, this is also lab stuff. It's where everything drains. If you know the lab stuff, you're going to know this. Nasal septum is the midline wall. When someone has deviated septum, they can't breathe from like one nostril. Sphenoethmoidal recess drains into the sphenoid sinus. So this is sphenoid sinus. This thing going through sphenoethmoidal recess. Then you have a superior concha, middle concha, and an inferior concha. So these are the bigger things. Concha, and concha, but they cut it off. Wait, make sure. Yes, so the things in between them are the meatus. So superior meatus, middle meatus, inferior meatus. Remember, in SpongeBob, he had a magic concha that he was asking questions like, oh, magic conch, should I whatever, blah, blah, blah. So the concha is the bigger one. The meatus is the stuff in between. So the superior concha, below it is a superior meatus, which drains your posterior ethmoidal cells. Middle meatus, over here you can have an ethmoid bulla and a semilunar hiatus. Ethmoid bulla gets your middle ethmoidal openings. Semilunar is going to get your anterior ethmoidal. So if you're going structure-wise from most anterior to posterior, you have this bulge is your ethmoid bulla, which is right here. Above here is your superior meatus. And then this thing is your semilunar hiatus, because it looks like a moon. So anterior to posterior, it goes semilunar hiatus, ethmoid bulla, and superior meatus. So this gets anterior ethmoid cells. This gets middle. This gets posterior. So that should make sense why semilunar is anterior, middle is, or ethmoid gets middle, and then superior gets posterior. The most anterior things also going to get the most anterior sinuses. So the front of your face, frontal sinus, front of your cheek, maxillary sinus. So all three of these go into the semilunar hiatus. And then your inferior meatus, you have your nasolacrimal duct. So when tears flow from your eyes into your nose, so we said tears are produced in the lacrimal gland, and then blinking spreads them from lateral to medial across the eye. And then the fluid drains through a bunch of things, and then eventually from the lacrimal sac it goes to the nasolacrimal duct. Now, I don't think she'll be too specific with these, but to remember that it goes, so this is lacrimal, to remember that it goes first puncta, then canaliculi, and then sac, you're going to remember if someone buys you a purse on Canal Street, so P, first puncta, C, canal canaliculi, S, sac, street, you're going to cry because it's fake. So puncta, then canaliculi, then sac, and then from the lacrimal sac, it goes to the nasolacrimal duct. So if a guy buys you a purse on Canal Street, such as they sell fake stuff, you're going to cry. I hope this helps. I know it was super long. But I really think this should be everything. So yeah, watch this. Watch the lab video. I mean, I'm assuming you already watched this by now. But thank you guys, and I hope this helped.